factors we keep changing according to the size of the patient, the size, according to the part of the body you want to examine. You can change those factors, kilovolt, kVp, kilovolt peak, and MIS, milliampere per second. We'll see them more when we are doing rotation, doing our rotation in radiology. But we keep changing those factors according to the size of the patient, to the part of the body you want to examine, okay? And like, for example, this was low kVp X-ray. Look how it looks like. And you see that you can miss something from the bones. But when we now want to see more the bones, part of the bones, you can use high kVp, like between 120 and 170, okay? You see those two X-rays, the two films are different. And that one, the second, the high kVp, the one we are looking at, can see it can show the small, like this small nodule, or even small calcification can be seen here. Even the bone itself themselves can be seen here better than the previous one. Look at the previous one, you can miss anything from any details. Small opacity, small nodule, small calcification, you can miss it here. But for the second one, you can detect them very easily. Okay? Is it okay?
Yes.
Yes.
Okay. So we have different views. We call them views when we are reporting X-rays, but when we are exposing the patient on the machine, we call it collimation. Okay, like views, we have posterior views. It's when the X-ray source is behind the patient, posterior. The patient is lying on the film, and the film is in front of on the chest of the patient, and the X-ray source is behind the patient. That is called posterior view. Contrary, the anteroposterior view is when the X-rays they are coming from the anterior aspect of the patient, okay, and the film is posterior to him, okay. A lateral view is when the patient, now the X-rays are coming from the side, on the side of the patient, when the patient is in erect position, standing on the machine, on the receiver of the X-ray. And lateral decubitus, it is still, the X-ray source is in front of the patient, but the patient is lying on the side, okay? Is lying down on the side, on one of the side, either left or right side, but X-ray source is in front of him, okay? This is different from lateral view. Lateral view, the patient is standing on the receiver of the X-ray, but the X-ray coming from the side. But lateral decubitus now, the patient is lying down on the table, and the X-ray coming from front. Explanatory film, it's when now, normally, in most of the cases, we expose the patient or the film when the patient is doing a deep aspiration. But there are some circumstances, some diseases where we order the patient to do exploration so that we can expose the patient. Especially, I'll give you an example in the case of, to breathe out, in the case of like small or mild pneumothorax, or in the case of obstructing lung diseases like asthma or other diseases of the same category. Or in the case of foreign body aspiration, we normally should request the patient to breathe out, so that now where there is air trapping, where there is pneumothorax, it can come out, because other part of the lung will be without air. But where there is now pneumothorax, where there is foreign body with air trapping, it can come out very easily when we are analyzing the film, okay? Something else we can do that's not done frequently is what we call fluoroscope of the chest, especially to see how things are moving when you're examining. Remember, fluoroscope is real-time examination. That is not done frequently. It's very rare, especially when we want to see if there is any foreign body. Something other views that are experimentally, that are done very rarely, it's about aortic view. The patient is now, the patient does sitting or seated on the chair in front of the X-ray source, and it can now, the patient can change the position lying down in front, and now here the aortic view and the reverse aortic view, you want to expose some hidden areas like posterior to the clavicles, or especially posterior to the clavicles or posterior to some bones like ribs. You want to change the orientation so that when you expose, you can not miss anything suspected posterior to some bones of the chest. And another view can do it is an oblique view. Oblique view is it's the view between the lateral and the posterior, the frontal, between the frontal and the lateral view. It's an oblique view. Those are different views you can do, but routinely we do posterior view and the lateral view. And the posterior view, it's when someone a patient can stand on the film, on the receiver of the X-ray, can stand there. That's when we do posterior view. Anterior posterior view, we do them in for children. You know, children cannot go and stand on the receiver of the X-ray, the young children. So we don't have any other option. We just do anterior posterior. And the lateral view, we do it when the posterior or anterior posterior, they are not, we have seen something that's not clear, especially for location. Remember, it's another view, it's another dimension. When you do a lateral view, it's another perpendicular dimension to anterior or posterior anterior views. Okay, so it's like you want to better locate any region in the chest. That's what, by the way, that's what I...
Excuse me, sir.
Yes.
Yeah, on the previous slide, I didn't understand. I haven't understand where about lateral decubitus view.
Decubitus, decubitus. The decubitus is especially, it is done when you want to see, you suspect, especially we use it when you suspect any small or mild pleural effusion. You know, that small fluid has just remained into the costophrenic angle. When you do a frontal view, when you say a frontal view, we are talking about either posterior anterior or anterior posterior. That's frontal view. Frontal view, whether it is posterior anterior or anterior posterior. So sometimes when there is any small pleural effusion, you miss it. You cannot miss it. You cannot see it on chest X-ray because it's very small. So when now the patient is lying on the side, that fluid will flow up. Okay, that fluid will flow up, and when we do now, we take and film where the X-ray source is coming from anterior aspect of the patient. You will be able to see that small fluid in the pleural space. Okay. You see, can you imagine? By the way, I may have some images on the other slides. I'll show you. Any question? Have you? Hello.
Hello.
Is it clear now?
Yes, is it clear? We can proceed.
Okay. So this is, I have already explained this. Normally, we do chest PA in most routinely, just chest posterior anterior, chest anterior, and there are some advantages. Maybe I will come back to them. when you do, remember the heart is an anterior aspect of the chest as location. So when we do a posterior X-ray view, it means from the physics, if you remember the physics, when a structure is far from the light, now that structure will become smaller, okay? But when the structure is near the light now, on the image, it will become more bigger. So that's the reason why we prefer to do chest posterior view, so that the heart doesn't become big. That's physics. Because the source of the X-ray source are posterior of the patient, meaning the heart is far from the X-ray source, meaning the shadow of the heart will become more smaller. So, okay? And we will not think of maybe cardiomegaly or something else like that. All structures will become smaller than for the anteroposterior views, okay? That's the reason why we prefer to do a posterior view of the chest. And again, the lateral view, it's also done frequently, but not routinely, unless you suspect something else. Lateral decúbitus for the conditions I told you, and the reverse aortic for apex of the heart, of the chest, of the lungs, especially the spaces posterior to the clavicles. For the ribs, normally if we are suspecting any fracture, or especially in trauma case, we can do AP, P and oblique for you to not miss any fracture. Ribs number 1 to 8 in arrested inspiration, and rib 9 to 12 on arrested expiration. Okay, so that you can be able to see very well the ribs. Otherwise, you can miss the fracture in any small any fracture of the rib. For the heart, I told you we normally do a posterior for the reasons I have told you, and the lateral view, because remember on posterior view we can only see the lateral atrium, the right atrium, and the left ventricle. And in lateral view, we are able to see the right ventricle and the left atrium. You remember on the anatomy, lateral view can help you to see the right atrium, the right ventricle, and the left atrium. Okay. For the diaphragm, a posterior is good. You can see, and also lateral view can show you the diaphragm very well. And for pediatrics, remember for children, I told you the reason why we prefer to do AP, because the children cannot accept to stand on the X-ray receiver until you finish to expose the patient. And the lateral view, they can still accept. If they sit on the chair, they are able to cooperate. They can cooperate, but otherwise they can't, especially for young children. So those are now images of the.
Excuse me.
Yes.
Lecturer, about those ribs, if you want to see all of the ribs from the 1 to 12, then we have seen that from the 1 to the 59, I don't remember where, we need to
Remember
have
when you do, I thought, yes, when you do, and we expose the patient a film in expiratory phase, what happens in inspiration? What happened to the chest? Some part of the ribs will go down. This expansion of the chest itself. Okay, do you get?
yes,
And now
but
you can miss the lower ribs. The lower ribs, you can miss them on the chest film. But when you do expression now, you can put all the ribs within the film because there is no expansion. Okay. Have I answered the question?
Yes, lecturer.
Yeah, we'll see it with time. If some, okay. So look here on this slide, we want to show how the posterior view is taken. Can you see this patient here? Can you see the positioning of the arms? The arms positioning. This helps to remove the scapula from the lung, from the field, the lung field. When you do this positioning of the arm, you are removing the scapula. It's like you are, rotating the scapula from the lung fields so that you cannot miss anything from the lung disease. And now the source of this is the technician, the source of X-ray is posterior to the patient. And now that will help you in giving this, the size of the heart will become smaller, not smaller, the normal, almost close to normal size of the heart. The patient has done deep aspiration. That's the reason why you can see when I tell you how we are able to know that it was in deep aspiration or not by counting the ribs, especially the ribs, either posterior or anterior ribs. What else? Yeah, there is no magnification of the image. That's the one of the main reasons of the posterior anterior view. Otherwise, you will see on anterior posterior how everything, the heart, the mediastinum, everything becomes bigger than normal. Okay? Is it okay? Is it clear?
Yes.
And on this drawing, this drawing, they wanted just to show how the heart is far from the source in the posterior. The heart is in the anterior aspect of the chest itself. This is the chest. The heart is located in anterior aspect of the chest. That's the reason why the PA, posterior, is better than anteroposterior by not magnifying the structures, especially the heart. Okay. Can I go to next one?
Yes.
Okay. So advantages of a pH view. It's best for viewing lung fields. You remember you have the patient moves the scapula away from the lung fields, and it also helps in avoiding pulmonary vessel engagement. You remember in AP, the patient is not able, as in PA, to make a deep aspiration. And the expiration can make vessels to be engorged. That also can change the normal structure of the lung or the structures in the lungs. Another advantage, it avoids magnification of the heart. I told you. It's very good for viewing the ribs, the diaphragm, and in trauma cases, though we do in expiratory and expiratory phase. And it is even more comfortable for the patient, especially adults, not children. Another reason for doing an EP anteroposterior is when the patient is very sick. The patient cannot stand on the X-ray receiver and take the position, the posture we showed. Okay. Okay. Are you following?
Yes.
Yes.
Okay. So how now? This is very important. How can you identify if the film is AP or posterior or anteroposterior? There are some key important, that's what we'll be using in rotation and reading X-rays. The number one, very important one, very important than others, it's to see if the scapula project outwards the lung fields. That's very more important than others. Others can still change, but this one, no. In PA, the scapulae project outwards the lung fields. Gastric air bubble, it is visible in erect position. You know why? Okay, this is another sign, but not very important, but it can help still. You remember, gastric air bubble can be visible, can happen. Can happen when the patient is in a erect position, standing, okay? But if the patient is is lying down, you can't see the gastric air bubble because you remember the air collects itself at upper when on the upper side of the structure, any structure containing it. Number 3, more vascular markings at the base due to gravity. That's another sign, but not that important as for the scapula projecting outwards. The vascular markings at the base due to gravity. Normally, the vessels, because of the thin wall, because of this, the thickness of the vascular, the wall of the vessels is very thin to be seen on chest radiograph. But in PA, when the patient is standing, there is more, the vessels contains more blood when at the lower part of the chest, I mean. Okay. And another sign is the dependent position of the breast. Come now at down, but in the AP it can change, the lateral view it can change, in the decubitus can change the positioning. Okay, those are the signs. This is a PAOP, but most important sign is appeal outwards. So characteristics.
About PA view,
Yeah.
because how they look on the image.
I know. ndaziba ndanabibabwira ahubwo ndababaza sawa okay sawa okay sawa nta kibazo aha hello, can you hear me? I'm using my phone. I'm using my phone. Could you hear me?
Yes,
we
sir.
can.
On phone.
Yes, we had you on phone.
I thought maybe when they called the internet is no longer there. So sorry.
It
That's
was
what
there.
Dr. Wiz.
You said you will finish tomorrow.
I will try my best so that I finish tomorrow. Tomorrow I will teach you in the morning. In the afternoon, I think we will finish my part.
Okay.
Afternoon, no?
I will teach from morning up to 12, and from 2 to 5, and I think we'll finish my part. I think. And now we plan with Dr. Louise how she can teach her part now. How is your plan next week?
We are available.
Are you available next week?
Yes, sir.
That's very good, and everything will be good. So, was there any question so that, or I continue this?
Question.
On
the previous slide.
Yes.
Point number 4, I'm not understanding it very well.
Dependent position is down. When someone dependent position is opposite to the gastric to air bubble in the stomach. Depending position is the lower part of the lower position because of the weight to something. The breast come down when someone is standing up. Okay, that's the reason. It is not that important.
Yes.
Depending position of CRV.
Of course, thank you.
This
Of course, I understood.
The same as for the vascular engorgement when patient is standing up, the blood is more in the vessels in the lower part of the lungs than upper part. That's dependent position also.
Very clear.
Okay. The gravity. Okay. So characteristics now of a good chest radiograph. Now hear this very well. Try to understand this very well. Because before you start analyzing a chest radiograph, you should make sure that it is very well done. If it's not well done, it can mislead you. Okay. Number 1, the whole chest wall must be included. That's very important. The chest wall must be included, up, down, left, right. Number 2, the whole lung field must be included. Ariko byo birumvikana niba chest wall irimo, even lung field will be in. Number 3, patient identification must be included. This is also very important. Identification. I know one African people, they don't give value to identification of people. That's the reason why you can sit with someone in a wedding for the whole day and don't even ask him or her the name. Patient identification must be included because you can do interpretation and give only disease to someone else because you didn't check the identification of the patient on the chest radiograph. Number 4, it must be automatically marked correctly. Marked, I mean the left side. Normally we put left or right to show you that this is left side or right side. Okay, it must be anatomically marked correctly. And the number 5, at least 9 posterior intercostal space, 9 posterior ribs, and 9 or 10 posterior ribs, and 6 anterior ribs should be seen above the diaphragm. Deep inspiration. For you to know that this film was taken deep inspiration, you should normally count either 6 anterior ribs above the diaphragm or 9 to 10 posterior ribs above the diaphragm. Okay? And the number 6, Vertebral spine should be faintly seen through the heart shadow. That is a sign of an adequate penetration. Vertebral spine should be faintly seen through the heart shadow. Faintly, I will show you how faint it can be. When do you say it is faint seen? Number C7, no motion blur. Normally, we tell the patient when they're exposing the film, we tell the patient to hold respiration. And then number 8, no radio opaque artifact. We normally remove all. That's the reason why I remove clothes from the patient before we do exposure to take film. The artifact, do you know what it is? Do you know what it is, artifact?
No.
Artifact, something that can on the film it has a dress with the shirt. You can see some buttons on the film or any other metal structure on the film, and you may even think that this is maybe within the body or not. That is an artifact. Anything that can be in the film why it was not supposed to be in. Okay. Number C6 and C7 should be included. That is now a sign that you have included the apex, the lung apices. C7, C6, C7 level should be within the film. Normally, we say that the soft tissue of the neck should be within the film. Soft tissue of the neck. And number 10 or something, no rotation. How do you know that there was rotation? It is that they say both sternoclavicular joint should be equidistant from the all same. line above the diaphragm. That's the reason why anteriorly this one cannot be counted. This one cannot be counted because it's not crossing the mid-clavicular line above the diaphragm. The diaphragm is here. So if I want to count now the ribs anteriorly, they count 1, 2, 3, 5, 6. No. 1, 2, 3, 4, 5, 6. Okay. But seventh one, I will not count it because it cannot cross the mid-clavicular line above the diaphragm. But now, either we count the anterior ribs, like now I am sure that this was in deep inspiration because I have at least 6 ribs above the diaphragm. For the posterior ribs now, it is even easier because I know this is the first anterior rib. If I follow it, the first posterior rib is here. This is the second one. If I follow it, the second one is this one, posteriorly. And this is the third one, 4, 5, 6, 7, 8, 9, and then 10. But we normally call it a deep inspiration when you can count at least 9 ribs above the diaphragm. And I have 9 already. Okay? If I give you another film, can you count these ribs I have the way I count them?
Yes.
Yes.
See how the costophrenic angle is sharp? See how the costophrenic angle is sharp? The angle is very sharp on both. It's like fluid within it. And those ribs, we count them on the right side, not the left side. Never the left, but the right side. Because remember, something else I have to tell you is that normally, in most of the cases, the right hemidiaphragm is positioned above the left one by 1.5 centimeters, I think. And even the left hilum, you remember this is the hilum, the confluence of vessels, pulmonary vessels. This is the left hilum, and this is the right one. Can you see how the left one is positioned above the right one? Can you see? These are signs. These signs are very important. They are very important because if now you see them at the same position, you will think of something happened. Something happened because how can they be at the same level? How can the diaphragm be at the same level? Either the patient, it is due to the patient position or from the disease of the lung, like in the case of what you call atelectasis or lung collapse. If there is any lung collapse somewhere there, it will pull on the hilum, and the hilum will be at the same position as the left one. Even the diaphragm will be pulled up, or if it is in the left lung, the diaphragm will be pulled up and it be the same position as the right one. And there is any mass in the abdomen pushing the diaphragm on the left will be at the same level. So those are any change from a normal anatomy. You should think twice and say, what happened? Let me look for something, the cause of this. Okay? Don't try to analyze the film without checking those normal characteristics. Because, for example, can you see that this is the aortic arch? This is descending aorta. Can you see the line descending aorta? This ascending is here. The superior vena cava is here. The inferior vena cava goes into the right atrium. Remember, this is the left ventricle. The right ventricle is in front. You can see it when you do a lateral view. Even the part of the left atrium is up there. And you do the lateral view, it is where you can see the big part of it. You can see the trachea is central. The left one is more horizontal. That's the reason why when someone has done has aspirated a foreign body, it has tendency to go to the right atrium, the right main bronchus than the left one, because this is more horizontal than this one. So this anatomy it has repercussion to the findings in some diseases. Okay, don't just think it is something very small. No, they are very big. Okay, very important ones. Okay, can I continue?
Yes.
Yes.
Can you see that the plural you can't see the plurals cannot see it unless the second, otherwise this line of the plural, but it's not second, there is no plural fusion because it is sharp, no plural fusion, it is sharp, you know. Those the heart you can see and there are some areas we call the hidden areas in the chest radiograph. Let me tell you about them. The space posterior to the clavicles. The space is posterior to the clavicles. The region posterior to the clavicles. It is hidden area. Remember, of the chest, of the lungs. The region posterior to the heart. Like remember, the lungs is not stopping by here. It is not limited here. Even posterior to this part of the heart, there is part of the lung. Okay, that's the reason why these vessels you are looking in here. These vessels are in the lung. They are in the lung posterior to this part of the lung, even there. So the space behind the heart shadow, it's a hidden area of the lung. The space is posterior to the clavicles, and then to the hemidiaphragm. Yeah? The space posterior to the diaphragm because the lung is not limited here. The lung goes deep. Posterior, it goes deeper. Even here, the lung goes deeper posteriorly. So you can diagnose any pneumonia at this part, at this region, any disease of the lung here. And the fourth one is, I told you this is one, this is two, this is three, another one, there's the fourth one. The fourth one is the hilum, I remember. The fourth one is the hilum. You can miss some lymph node or a mass in the hilum because the hila, they are dense, they are opaque. If you don't see very well, you can miss any small opacity in the hilum. That's the reason why you call it hidden area. So the hidden areas of the lung should look twice region diaphragm. Okay. Slide.
Yes.
Muranyikiriza nari nzi ko wagira ngo mwabiza hano ni bwa kabiri muri kubisubiramo. Ndabizi neza ko this is okay, maybe ni muri practice nibwo muzabishobora kubyumva. So, who can unfortunately who can tell me how many ribs we do we have anteriorly? How many ribs?
You have a way anteriorly.
Remember, you have to count them on the right side. How many? If you tell them the first number, I will know that you don't know how to count them.
There are 7.
Who said there are 7? Listen, this is number one, okay? 2, 3, 4, 5, 6. How can you count this? And remember, the condition is you should count the ones crossing this clavicular line above that is not counted. Hey,
Excuse me, sir. I haven't even understood how you count those ribs.
Hello. Sasa mwebwe murabanebwe ngo murambwira ngo yes it's okay tugende kandi mutabyumvise ubwo ni ubunebwe. scientific weakness, laziness nako.
lecture ikibazo
Ikibazo kiri he? Mutabyumvise ibingibi ntabwo muzigera gutsinda ikizamini cyanjye kwanza. Radiation ntabwo muzanabikunda.
lecture
Yes.
ino rib ya mbere iri gucrossinga na clavicle ntabwo uri kuyibara.
Ndayibara, reba hano. Ntubona ko inyeri ya mbere anteriorly, mwibuke ko anteriorly ziri oblique. Anteriorly ziri oblique. Remember, anterior ribs are the ones on oblique.
Yes.
They are not in these ones. These are posterior.
Abo niho byari byagoranye.
Nubwo byaba atari ibyo wari warebye, still the posterior ribs are not 7, they are more than 7.
Nako twari twashizemo kamwe.
Yeah. Oh yeah. So the anterior ribs are this is the first one here. This one anteriorly. Second, third, fourth, fifth, sixth, and seventh. Seventh is not counted because it does not close this mid-clavicular line above the diaphragm. Since ko muri kubyumva ngibyo.
Very clear.
And who can count for me the posterior ones then?
Me, I can try.
Yeah, count and tell me the number. I will know that you know how to count or not.
It's 9.
They are 9.
No, they are 7. Seven.
Yeah. They are not 7. Look. I don't since come kubiri bamwe ariko. Can you see my
You are seeing your cursor.
Look.
Ntabwo turi kubibona neza.
Urabizi uziko impamvu nkunda kwigisha online, do you know why?
No.
Online you can see the images better than in class.
Yes.
I know. Because if you have your computer and you see what I'm showing, you can see it better than on projection. I know. So kukiva unakuona neza, look here. This is the first rib anteriorly. And when you follow it, you see the posterior part of it is this one. And the second rib anterior is this one. If you follow it, the posterior part of it is this one.
True.
So this is number 1, this is number 2.
Yes.
And the rest is easier because it's clear. The rest is number 3, 4, 5, 6, 7, 8, 9, 10. Unaweza kumwambia kulizingo 7. How about the 7? Unasita kosa.
Lecture nje ntabwo mbibonye.
Kandi ibyo
Nje ntabwo mbibonye icuma hano.
Lecture bino ntabwo turi kubibona kabisa.
10 muzikuye he 10?
Ariko karebe ngakurikira rebe hano. Look, ese ntabwo mfite computer si.
Iyo point ntabwo turi kugenda tubibona, iri kugenda gakeya.
This is iragenda buhoro. Sorry.
Wasanga ikibazo cya connection.
Then let me go very slowly. This is the first rib anteriorly. Murayibona?
Yes.
The first rib anteriorly.
Yes.
If I follow it, it is the posterior part of it is this one. Can you see?
Yes.
Okay. The second rib anterior is this one, unless you don't agree with me.
Yeah, we agree.
If I follow it very well, the posterior part of it is this one.
Yes.
Yes.
Simple. Because the first 3 or 2 ribs, they are supposed why I start by anterior aspect.
Yes.
Okay. The rest is simple. 3,
4,
5. You can continue. 6, 7, 8, 9, 10. Okay.
I see.
Okay.
harya lecture
Abana rwose.
iziri anterior nizo ziba ziri oblique.
Anterior nizo ziba ziri oblique buri
Okay.
gihe.
Yeah.
No muri AP yaba AP yaba PA, the anterior ones are oblique, in oblique direction, and the posterior one are more horizontal, like always AP or PA, and always this is the right side, this is the left side, always PA AP. Okay.
Yeah.
And and I ask you another question. Is this in rotation or not?
No rotation.
Yes, there is.
No rotation.
There was no rotation.
Yeah.
Why? Okay, maybe you cannot show nicyo kibazo cya online. I would like you to show, but the medial end of clavicle here. Okay, can you see? The distance from here to this, the spinous process, they make a line, a vertical line. Can you see the line? So the distance from this, the line made by the spinous processes to here is almost the same as from here to there. The same. So not by millimeters, but almost the same. Meaning there was no rotation. Okay.
No, don't get it where. Can you come again?
Wrong, Maga.
With rotation.
For rotation, the film should be symmetric. We say that it is symmetrical when the distance from the spinous process is line. Look here. This is the spinous process, the line made by spinous processes. Can you see them? Can you see the line? Can you see the line? Umuntu wansubize niba abibona.
Yego turi kuyibona.
So ntabwo mubona se
Yes.
the middle end. And the distance from the spinous processes to the right clavicle to the spinous processes, middle
They
end
are
of
equal.
clavicle, the distances are the same. By estimation, they are the same. Okay?
Yeah.
So if they are the same, it means there was no rotation. The film is symmetrical. If they are not the same distances, it means there was a rotation. And where there is a big distance, it is where the patient was rotating to. Turaza kubireba image ngira ngo abigaragaza. All right, is it clear?
Yes, it's clear.
Those are normal characteristics of a normal film, PA. Again, check, what do you think
I
this
have a
is?
question. About the deep inspiration, we found out that the posterior ribs, they fulfill the criteria, but the anterior rib does not. Does it mean that it is not deep inspiration?
I said the criteria, you count either the posterior ribs or chamber. Do you agree with me? That's what I said. You count either. You count either the anterior or the on the right side. Okay?
Yes.
So if we choose to count the anteriors, we have seen that here we have what deep inspiration or not. So if you choose to count the anterior ribs, counted and the This is not sharp.
It should
There
not be
is a rib here.
Hey.
Don't consider the rib. That's air space. It's sharp.
ese lecturer
Sharp.
ko gastric bubbles zaje muri left side
Ubundi se ziba ziri he? Igifu cyawe kibemo iburyo se? Igifu cyawe kibemo abantu bagira ibyo bita situs inversus.
nibyo nari nibagiwe
Arawe.
So my question is this: why the diaphragm on the left is the same level as the right side? That tell me the reason. Because this is not normal. If you are not able to answer the question, it means you didn't understand my 9 characteristics. Or my 11 or 12, by the way.
lecture ubwo ni ukuvuga hari ibintu byapushinze nyine left lung
wenda byayizamu byayikuruye wenda it has pulled it. That's what I wanted you to tell me. Okay, maybe you are still very very young in this, but look, gastric bubble is somehow the gastric fundus, the somehow distended, gastric distension. It's not the same size, the normal size of gastric air bubble. Can you see? It has the patient had a lot of gas in the gastric fundus. So that a lot of gas now has pushed the diaphragm above. This can even cause the chest pain, chest pain. Sometimes the patient comes saying, I have chest pain. And when you look, you see that there is either intestinal gaseous distension pushing the diaphragm and making some compression to the lungs. There is no other sign, but it is pulled above by gastric bubble. And it becomes now the same level as the right one. Okay. And what else? Say we have checked all the normal. This is a normal chest radiograph, how it looks like. Another thing I didn't tell you is about how to measure the normal size of the heart by what you call cardiothoracic ratio. Do you remember CTR, cardiothoracic ratio? Have you heard about it?
Yes.
It is the size of the heart shadow. The size of the heart shadow divided by the distance of the chest wall. And the chest wall distance should be measured at the level of the diaphragm. And they count, they measure from in to in, not out of the bone. In to in, at the level of the hemidiaphragm, of the diaphragm. Now you count the diameter of the heart divided by the diameter of the chest wall. And when it is less than 0.5, it should not go beyond 0.5. In a PA, this is counted in a PA view, not in the AP. Remember, in the anteroposterior, the heart becomes a bit bigger than normal. So this is only measured on PA view. Okay?
Yeah.
Can I continue?
Yes, sir.
Yes.
Yeah.
Okay. So, an AP view can either be taken when the patient in a supine position lying on the bed, on a table, or when the patient seated on a chair. Like in this case, the patient was lying on supine position on a table, X-ray table, You can see the X-ray source is in front of the patient, and the film is behind. Someone can switch off your mic, please. The patient, the film now, the cassette is inserted here, posterior of the patient. Okay. So there will be magnification of the heart size for sure, because of the physics I told you. And in this position, remember, in most of the cases, the patient is very sick and cannot even do a deep inspiration. For us to expand very well the lungs, in a PA, posterior anterior, the lungs are very well expanded. You can see the majority, the maximum of the part of the lungs can be seen in the film. But in a PA, it's not that easy, because I think on this, the film taken like this, I will see the elevated diaphragm. The diaphragm will be elevated because there was no deep inspiration. I will see the lungs, the vessels, blood vessels in the lungs will be engorged. What else? The heart will be big, the mediastinum will be bigger. So those are the changes we can see on AP, anterior posterior. And you know the reason why we choose to do IP, especially for children and when the patient is sick or old enough not to make a PA. Otherwise, we prefer to do a PA. Okay? So disadvantages of PA, an AP, sorry. Number one, shallow inspiration, I told you. Crowding of vessels, I told you about this. Can mimic interstitial lung disease because of those linear opacities of the vessels. Widening of cardiac shadow and mediastinum, twabivuze. Shallow costophrenic angle, they are not sharp as for PA. Shallow. Layering of pleural effusion. Pleural effusion, yeah, you can see, and the uniform vascularity of entire lung. Normally, the lower part of the lungs, they have a more vascular markings than the upper part because of the dependent area gravity. Fluid layers are behind the lungs. Fluid layers are in costophrenic angle in case of pleural effusion. Now, the fluid you cannot see in front. It is posterior because remember the lungs, costophrenic angles are more posterior than the anterior one. More deeper in the posterior part than anterior. You see, that's the reason why sometimes you can miss the fluid, small pleural effusion. You can miss it on a frontal view, and you go to lateral decubitus for you, or you do chest ultrasound for you to diagnose it. Okay?
Yeah.
So compare these two. Want to ask me a question? Who want to ask a question?
No question.
No question. Okay, take time to compare these two. Compare these two films and tell me the differences.
Sharp costophrenic angle, PA view.
PAV sharp costophrenic angle, you are right. This one on the other side is shallow. They are shallow.
Shallow, yeah.
What else?
Cardiomegaly on AP view.
Cardiomegaly. Not cardiomegaly. The heart is enlarged. Because when you say cardiomegaly, okay, the heart is enlarged compared to this one.
Yeah.
What else?
No gastric bubble on AP.
Yes, no gastric bubble on AP. But here there's gastric bubble.
And the lung field become small because
they are not expanded. They are not expanded as on a PA view.
Yes.
And how about the vessels of the hila?
Yeah.
There are many on high-ram vessels, especially
Yeah, they are
on
somehow
the
they are
right.
prominent here compared to this one. They are somehow bigger than this.
The clavicle on PA view are lateral.
On PA they are horizontal, not lateral, horizontal.
And I have seen that the diaphragm become like big.
Yeah, they are not. There was no deep inspiration here. I mean, here they are somehow elevated, not big, elevated. They are not depressed because of the inspiration. There was shallow inspiration here compared to this deep inspiration on the PA. Okay? How about the scapula? Check the scapula. Hari abantu bari kurangara kandi turi kuvuga ni ibintu bikomeye kuri mwebwe. Ni akazi kanyu. Hari abantu bari kwivugira ibyabo.
Scapula turning outward on PA view.
Check. That's very important, by the way. And on AP, you know the scapula are within the lung field. But on PA, they are out.
Yeah.
The scapula are out. And that's very important. The sign that this is a PA. Without even mentioning that's a PA and AP, you can look at the film and say, this is a PA, this is an AP. Okay?
Yes.
Okay. What else? Is there any rotation or not?
Actually, no rotation.
No rotation.
No rotation.
Yeah, no rotation.
Okay. Like this one. Check how they wanted to. This is a check how that. Check also these two. Compare the two and as I'm doing it, let me do some exports on the phone, my phone. As check the differences.
Lecturer, on poor inspiration, there is opacity on the below of
on the lower part of the lungs.
It's more white, yeah.
Opacity. That's there is a reason why I have put these films for you. Do you know the reason why it is there? It is white here, like opacity. It is because of it is because of poor inspiration. Because not much air has reached the lower part of the lungs. You may think of opacity, why it is not. So the X-ray characteristics are very important to check before you analyze the film. Okay? The costophrenic angles are not sharp, they are shallow compared to this one. The heart is a bit bigger than this. Okay, they're almost the same. No problem. But there was over penetration on the film because the lungs are over exposure. I will tell you the difference between exposure and the penetration of the film. Like here, there was. You remember I told you about good penetration. I said the spine should be faintly seen through the heart shadow. Like now, here on this one, you can see the spine, but it is not clearly seen. It is faintly seen. Faint is something that's not seen very well. It's faintly seen, not clearly. Faintly seen, so meaning this is a good penetration. Penetration is done by kV, kilovolt peak, not milliampere per second, not MIS, milliampere per second. Milliampere per second, it increases number of X-ray. But kilovolt, it increases the intensity, the power of X-ray. So the penetration is seen by checking the spine, the bones, especially the spine. But the exposure number of X-ray can be checked by looking at the lungs. Like now, the lungs are too dark, meaning we have sent a lot of X-rays, but those much X-rays are not intense, are not powerful. Meaning here, if you want to collect these two, I will tell the technician to go and reduce the MIS, the number of X-rays. But he doesn't have to reduce the KVP. mwabyumvise sinzabasobanurira mwaje muri situation ngira ngo kubera yuko on the theory here it is a bit difficult to understand, but on X-ray machine we have a button for KVP to increase and reduce, and the button for MIS to increase and reduce. When you increase the MIS without touching on KVP, you are sending too much X-rays, but without increasing the power, the intensity of those X-rays. But when you increase the KVP, you increase also the power, the intensity of the X-rays you have produced. Okay? Sinzi ko muri kubyumva.
turi kubyumva.
So like this X-ray, normally if you check the penetration, the KVP is good because I can see the spine faintly, but the lungs are too dark, meaning they have sent a lot of much X-rays, but the power was normal, but too much. The power of X-ray, producing X-rays is good, the penetration is good, but the number of X-rays is too much. That's the reason why they made darker the lungs. Kandi ibi ngibi nabyo bishobora gutera ikibazo kubera yuko overexposure, umva haramutse hari opacity, if there is no opacity here you cannot see it, if there is no opacity here you cannot see it. So meaning these films are overexposed but with good penetration. Okay?
Yeah.
Sinzi ko mubyumvise.
Gake.
Bizagenda bizaza if time. Sibyo?
Turategereje. Turabitegereje.
Ibiki? Bizaza? So adequate inspiration if you can count ibyo twari twabibonye. So you know that there is a let's maze subize no mu gato ndaje. Okay, you know that there is a what you call portable X-ray. There are fixed X-rays in the radiology, but there's also portable X-rays where you can displace the machine and go to the different department or what to do an X-ray of the patient, especially for sick in ICU. For example, it's for very sick patient. So this, it can produce an X-ray, but the X-ray produced is not the same or of the same quality as the ones from the fixed machine, because the distance from the focus from the source and the film, this is focus film distance, that's FFD. Focus film distance is short. When it is short, it means everything will be magnified. Okay, that's one of the advantages. Number two, the high KV technique, it's not possible. Bakoresha always the low KV technique kugira ngo bagabanye radiation y'abarwayi, uziko n'abandi barwayi baryamanye nayo baba exposed. Number three, this machine has longer exposure time than the normal fixed machine. Longer exposure time. Okay. Number four, as the advantage in the positioning of the patient. Those patients, they are not positioned as you wanted. We just make sure we have gotten the film, but it's not a good positioning. Is bad. Positioning is bad. There is always almost rotation. You know, cooperation from those full inspiration. You cannot make full inspiration those very sick patient, meaning the lungs will not be expanded as we wanted. And there is scatter radiation because in the fixed machine, there's some material put in the machine so that there is no deviation of the X-rays and taking another direction. So those are the disadvantages of this portable machine, but we don't have, sometimes we don't have other options and we use them. But make sure when you see it, you see the film produced by these machines, you can know immediately that this is from the portable machine, because the quality of the film is not the same as what you have just seen. Okay?
Question.
Yes.
Do we have this movable machine in our hospitals?
Yes, we have them everywhere.
Okay.
Yeah. We use them. We use them for in ICU, very sick patient, for neonate patient. We have them. Okay? Komeze?
komeza.
So, a lateral view, you should first know the anatomy. Should first know the anatomy, you know, what it can help, first of all, to locate, I don't want to read this, to locate where there was if you have seen an opacity, any abnormal structure, you can do a lateral view to locate it. Is it on the skin? I told you last time. Is it in the lungs? Is it in the heart? Is it in the posterior to the spine? You know? And all, if you suspect any aortic disease like aortic aneurysm, you can see that the ascending aorta can be seen very well. The aortic arch, even the descending one. If you want to check the left atrium, this is the left atrium, the lateral view, and the anterior ventricle, anteriorly, the ventricle, right ventricle, I mean. The hila regions can be seen very well, better than on front of you.
It's moving.
I don't want to come to
saw it in my
The breast, these are breast. This is the sternum, can be seen on lateral view if there is any sternum fracture or not. You see, lateral view has its advantages, and it's the complementary to front of views, okay? And it can be requested, especially to locate a disease, especially to locate a disease or to see better the anatomy in the chest, okay? That's how now it is done. You see, the patient is now amazing and the X-ray source is coming from the side. Okay? The X-rays are coming from the side. Yeah, what else? Ask me a question.
No question.
No question. This is clear, very clear how it is done. This is an anatomy. Remember from the first pages I told you, slides I told you about the anatomy. You can see the aorta very well. You can see the trachea very well. You can see the hila region, the many bronchi very well. You can see the esophagus. If there is any esophageal disease, you can see it better because now you can separate the esophagus from the trachea or other structures. You can see the spine, vertebral bodies very well. The diaphragm very well. If there is left hemi diaphragm or right one, remember the right one is superimposed with the heart anteriorly. You can see the gastric bubble, even the colon gas. You see the posterior ribs, you can see them very well on the lateral view. Horizontal fissure, that's imaginary line for the oblique ones. So this is anatomy of the lateral view of the chest. You should know it so that when you do a lateral view, you can recognize the anatomy and recognize the abnormal structures. Okay? Is it okay? Still the same. Now drawn on the same. The heart, right ventricle anteriorly, left atrium posteriorly, gastric bubble, the diaphragm, the spine, the mandibular and the sternum, the trachea and the esophagus. You can differentiate them very well. Costophrenic angles, you know, this is for left, this is for right side. The left is this one, because the left is the one superimposed with the diaphragm, the left costophrenic angle, and the right one posteriorly, and anterior aspect of them, they are there. So, you know, the lateral view is also, the anatomy is clear. It can even give more details than the front of view. So this is now the anatomy on the lateral view, the anatomy on the hila structures. The aorta, you see, at the left pulmonary artery, you see. aortic arch here, the aortic pulmonary artery. You can see this is the pulmonary trunk, this one. Right upper lobe bronchus, left upper lobe bronchus. You know, those are the structures of the hilum should be recognized from the lateral view. So, when do you use the lateral view? I told you, shallow show the region that may be obscured by heart and the diaphragm. Remember the hidden areas of the lungs. Can localize the region anterior or posterior. I told you, demonstrate any characteristic outline, lobar effusion, or lung collapse, especially middle right lobe lung collapse, demonstrate interlobar fissures, confirm anatomical abnormalities, depressed sternum, in case of trauma maybe, demonstrate heart and the aorta, you have seen, show retrosternal masses, mediastinal masses, that may appear as wide mediastinum on a pier. If you do a frontal view and you see that this mediastinum is widened, you can do lateral view to see where is located really, where is that any, where is the mass, okay? So lateral view is very important also. So lateral decubitus now. Tumaze kugira saa ngapi? Nakyali saa. Lateral decubitus, it can demonstrate now a pleural effusion in a patient who is too ill to sit up. That's one of the reasons. Remember the one who asked me about lateral decubitus, the positioning, I'll show him. But when there is small pleural effusion, or for the patient that is too ill to sit up, and that X-ray and lateral decubitus can detect up to 50 to 100 mils. It can help in diagnosing the pneumothorax, patient lying on the unaffected side. You remember the air will go up. If I have the left side of the pneumothorax, I will do right lateral decubitus, and you see my line of the air in the pleural space on above the another lung. It can show effusion, patient lies on affected side. Now, for the effusion, the patient will rely on the affected side. But on pneumothorax, the patient will rely on the unaffected side. Affected side on pleural effusion, but unaffected side on pneumothorax. When there is gas under the diaphragm, patient rely on the left side. Yeah, this is the left lateral decubitus, left side of the patient is against the table. When you are requesting this lateral decubitus, you call it left lateral decubitus or right lateral decubitus. When you say left lateral decubitus, the patient will lie on the left side. Right lateral decubitus, the patient lie on the right side of him or her. Okay? Any question here? If you can't. If you suspect the pleural effusion, you remember the indication of lateral decubitus twaime. Indication ya mbere, it is when you suspect small pleural effusion. Okay? Yeah. The second indication is when you suspect small pneumothorax. The third indication is when the patient is too ill to sit down, sit up or stand up. Yeah. Okay? Yes. So when there is any suspicion of pneumothorax, you will make a lateral decubitus where the part of the lung that is not affected is lying down, pneumothorax, because the air will collect above the structure. And when you suspect pleural effusion, the patient will lie on the side that is affected. Yego, and impamvu nabwiye mira mirongo ya nyuma no kugira ngo wowe nk'umuganga uzamenye how to request them. Iyo wivugiye ngo I need a left lateral decubitus, wabisobanuye ko uvuze ngo umurwayi aze kuryama left side ye ari iri hasi on the table. And when you call it right lateral decubitus, it's when the patient is lying down, when the right side of the patient is against the table. Yeah. Okay? And wowe uzi impamvu wanditse wase right lateral decubitus cyangwa left, urayizi wowe nk'umuganga uzi ibyo gutekereza. Niyo mpamvu nigeze kubabwira ko for any radiological examination, there are 3 people who are involved: the clinician, the technician, and the radiologist. Okay.
Yes, sir.
Okay, so this is now how the position. This is the positioning of lateral decipiters. Which lateral decipiters is this?
This is the right.
This is right lateral decipiters, and I know very well the reason why they have done. What do you think the reason why they have done this? Can you see that the patient is lying on right side and the X-ray source is behind him, either behind or front? You can choose, either behind or front. This is behind him. Can you see the source here?
Yeah, the source is behind.
Aha. So tell me the reason why they have done this. The lateral decipiter.
Maybe afite pleural effusion muri lateral side. I mean the right side.
Why in pleural effusion? Aha, that's good. Can you see that this is now the left lung? That is normal. The left lung is normal. There is no pleural effusion. But when you come to this one, you can see that air fluid level. That's the pleural space, fluid in pleural space, and you should see how it's very clear on lateral decipiters. Okay, this was there's much enough to be seen on front of you. They just wanted to show maybe people how the lateral decipiters can be better than in showing the pleural effusion. Okay. So other supplementary projection as well, aortic view used to demonstrate questionable apical opacities, the regions behind the clavicles. Patients stand erect or sit facing the cassette, and with the hands for support. As is in my way, the hands for support. Patient bends backwards to make 45 degree at the waist. Center of the middle of the level of T4, the center of X-ray source. Can you see? This is aortic view. Maybe the text is not easy to understand, but when I do this, you understand very well. Look, the patient is sitting on the chair, the cassette in front of him. Now, he does 45 degree backwards. Now the X-rays are perpendicular and at the level of T4. And now the clavicles are now above, they're out. The clavicles are out of the lung fields. If you're suspecting opacity like here, you can see it better. But before, in front of you, you could not see it. On a normal PA or AP, you could not see the opacity very well, the mass or something. But when you make this aortic view, you can see that region very well. Okay?
Yeah.
Is it clear? Somehow not. It is. You see, okay. It is done very rarely when you are not able really to see what is going on at apical regions, but it's easy to do. But that is now a aortic view. Can you see how the clavicles have gone up? The apical regions are very clear. Everything else is magnified. The heart, the mediastinum is magnified, but that was not our intention. That was not our intention. We wanted just to see the apical regions of the lungs to see if there is any opacity or not. Okay?
Okay.
That's the view. We don't care about the other part of the lungs, like this base of the lungs. We don't care. We wanted just to see. It is a supplementary or complementary view. Okay?
Yes.
Okay. Another one is reverse. No. Reverse positioning a reverse aortic view. This is a reverse of the previous one. Okay?
Ikibazo kuri the previous slide.
This one?
Yeah, this one. Ko banditseho AP elect.
N'ubundi ni It was AP.
Yeah.
Katreve, AP elect. Maybe it was this one because reverse aortic view and the aortic view. Kumungu, this is an AP elect. It is a reverse aortic view, but it's in AP erect. The patient is in erect position, AP view, but it is reverse aortic view. Maybe they wanted to just show this one. Sorry.
Okay.
Maybe it was this one because it's in AP, anterior posterior, in erect position, but it was a check. It was a reverse. The clavicles cannot be at that level there. So it has a reverse aortic view. That's the reason why they have written this. Okay?
Yeah.
So that is the reverse aortic view. The patient in erect position, this positioning. Yeah.
Yes, sir.
Okay, the same. Okay, the same. Clavicles are above, the apical regions are very clear. The lower, the base of the lungs, and we are not concentrating on the base of the lungs. So don't say that they are not clear. If you have made this view, we don't care about what is going on because you had seen it before at the front of you. So we are focusing on these apical regions, okay?
Yeah.
So another supplementary projection is a posterior oblique. I told you that it is made special for trauma cases, and want to view pleural plaques and pleural plaques in the case of atheromatoous disease, and other pleural and chest wall lesions like pleural effusion or something else, or pleural calcification. It can demonstrate lower lobe collapse. Foreign body in the esophagus, because the esophagus will come out, the patient back towards the cassette. That's the positioning towards the cassette, then rotate 45 degrees on the side, so the affected side is against the cassette. By the way, when you want to see, like we have seen an opacity in the left lung, and you want to do a lateral view and a oblique view, the side that is affected should be near the cassette normally, because it will be more clear. Okay? Ivyo mwalimu ubizi se? Ntabwo nabibabwiye. The affected side normally in the lateral view or oblique view should be near the cassette, not near the source of the X-rays. Okay? Like in this oblique, posterior oblique, you can say posterior because, listen to me, listen to me. They called it posterior oblique because the posterior aspect of this chest is against the cassette. If the anterior aspect was against the cassette, it should has been called anterior oblique. Okay?
Yeah. Yeah.
Like this one, who can name this one very well? Name this view. Name it very well. Give it a name.
Si yanditseho se ubwo ngubwo.
Oya ntabwo bihagije. Ntabwo yuzuye.
Okay, we should include the side, the right side.
So iyi ni iyihe rero? Ntabwo ndi kumva neza. Right posterior oblique. Okay? Yeah. Because the posterior right side and posterior part niyo iri against the cassette. The cassette. You go contre the cassette. Okay? Yeah. And look how it will show. Look how the oblique one will show the other aspect of the chest we should not see. The heart is distorted. The mediastinum is deviated. You can see the costophrenic angle very well, the posterior very well. Like maybe you had missed this small pleural effusion here. Can you see that the costophrenic angle is blunted? It's not sharp.
Yeah.
Yeah, and because we have done right oblique, we are focusing on the right side. The left side is ignored. Okay, that's the reason why it's not clear. Don't think maybe don't start now talking about the bad quality on the left side, because we are focused on this. You see that if there is any fracture on these ribs, you can see them very well. Okay?
Yeah.
Okay.
Yes.
Expiratory film and expiratory film, remember, can you request expiratory film? Expression film when there is, you suspect any air trapping. Air trapping can be caused by any air obstructing disease, like asthma, like foreign body aspiration, inhaled foreign body, because there will be air trapping, demonstration of small pneumothorax and live because when you made a deep inspiration, when the patient deep inspiration and you take a film, you may miss small pneumothorax because the lungs will be filled with air and you cannot differentiate where is air in air in the lungs, the expanded the lungs, and the air in the pro space when it is very small. Okay? For the inhaled foreign body, where there is a foreign body in the bronchus, and you do expiratory film, there will be air trapping there, and you can differentiate where in the part of the lungs where there is no air with that part of the lung where there is air trapping. Okay? Mwumvise akamaro ka expiratory film?
Yes.
That's very important, by the way. Kandi iri mwebwe mu byaka ntabwo ari iwacu tubijya akoresha telefone yanjye ariko nta kintu mbwira baza nta kibazo ye mu minsi ntabwo nari ndiyo ariko mu minsi yakoraga nta kibazo kaze nkubarize ndakubwira okay, sorry, mwumvise akamaro ka expiratory film, chest film?
Yes. Oh, yeah.
Yes.
Okay, that's good. Let us go to fluoroscopy. Nayo ntayikorwa cyane, it's not done frequently. It is when you want to differentiate peripheral pulmonary from extrapulmonary opacities. Hari igihe ushobora kubona an opacity on chest and you wonder if it is within the chest, the lungs, or out of the lungs. You can do fluoroscopy and see it very well. You want to demonstrate bone destruction. In a real-time examination, we want to show extent of encysted pleural effusion or empyema, especially in most of the, encysted or loculated pleural effusion. It's when some pleural effusion is enclosed into a cyst, it's enclosed somewhere, and this is normally caused by empyema, pus. In the case of TB or something, another infection by pus, when there's pus, there is now the wall, the pleura is thickened, and it can cause a scar. When it is a scar now, the fluid is assisted into the fluid pass is assisted into the cavity. Okay, that's what we call encysted or loculated pleural effusion. So this is now indication of fluoroscopy, but it's not done. X-ray cannot miss. If X-ray needs, can do a CT scan, and CT scan cannot miss. You cannot. I don't see fluoroscopy being done on chest. Okay. So air trapping, check. Like this case, I think there was foreign body aspiration. Check how on the right lung there was air trapping in expiratory phase. This is expiratory phase, and there is air that doesn't come out. But in the left side, the lung, the air has come out. So you can easily differentiate where is air trapping or where isn't, okay? This is lateral view of it. There is air trapping at that level. Can you see the role of expiratory film?
Yes.
And I tell you the truth, if you had done an inspiratory phase, deep inspiratory phase of this film, you should not differentiate if there is any air trapping somewhere. Because if even this lung will become dark, this one will become dark, so you can't differentiate them. I want to just recall here.
Question.
Uh-huh.
On the lateral phase, how are you discerning that there is air trapping?
Because the rest of apart from here, in expiratory film, why in expiratory film, why can you see a collection of air somewhere there? How? It's like you breathe out the air, because the air, how can it be trapped here? Can't.
Yeah.
Okay? Normally.
Okay.
Is it clear?
Yes.
So this is the core of anatomy. I know this is for you. It's for you to still remember, always remember the structures in the chest. Because if you don't remember these structures, don't think you can make a diagnosis. If you don't know that there is a left pulmonary artery here, you cannot make a diagnosis of pulmonary hypertension. If you don't know that there is an aortic arch here, NACO, you cannot know if there is any, aortic aneurysm or not. If you don't know the left atrium, left ventricle, and right atrium, and that the right ventricle is in front, you can't really make a diagnosis of heart diseases. If you don't see that spira vena cava is there, remember that on chest radiograph, you don't see it as you see it here now, because it is posterior to different structures. You cannot make a diagnosis of any disease. You see, so you should have this image, this anatomy in your mind, for you to always make the proper diagnosis. Hari igishasha kiri muri ibi ngibi ntimuyizi se anatomy nk'ini mwari muyizi se, you know it?
Ntacyo.
Nta kibazo. Good. So rero this is now when dufite iminota 30 kugira ngo turangize saa 11, 20 somehow 34 minutes. In part, it's like another chapter. We have introduced it already. It's about how to interpret chest radiography. No, we want to go into details, but you have already some message or some knowledge about it. I don't know if you can stop here and continue tomorrow morning, or you can continue and finish it.
So continue tomorrow morning.
Continue tomorrow morning.
Tomorrow morning.
Okay, no problem.
Every morning.
Okay, no problem.
Tomorrow morning.
Tomorrow morning.
We have Zamangwa.
Listen.
Continue.
Listen a bit.
Yes.
Okay, tomorrow at which time then?
5 a.m.
At 9.
At 9? I think 9 is okay.
At 8.
It's okay.
If we
At
think
5.
let me talk to let the CP answer the question then.
Yes.
Okay. At 8.
CP from Wutale, Arafat, at which time tomorrow?
At 9.
That's CP. Arafat is in Mugori. And from Gako? At 9.
Gako at 9.
I think 9 is better than the 8. What is that at 9? At 9.
Yes.
Yeah.
Okay. So have a nice evening then.
You too.
Goodbye.
Goodbye.
Thank you.
Thank you.